But what he's saying is not the problem. The problem is that in that paragraph, registered nurses are not recognized as individuals authorized to administer deep sedation or general anesthesia. Now you may be saying, well, we just heard that Sedasis isn't delivering deep sedation, so what's the problem? The problem is on the next page in that document from Medicare, they state that Propofol in colonoscopy is deep sedation. And I think if Dr. Egan and Dr. Rex have a problem with Medicare with respect to advancing the use of this technology, this and the absence of a nurse as a recognized provider, that's the problem, not a prohibition against a non-anesthesiologist using these drugs. Now, it's not entirely accidental, or it's understandable that there would be confusion on this point, because this graphic accompanied the interpretive guidelines. And here you see anesthesia, including deep sedation, to be given by anesthesiologist, CRNA, or anesthesia assistant within the scope of practice. This graphic is just wrong. It is entirely inconsistent with the accompanying text in the interpretive guideline, but more to the point, it's entirely inconsistent with the actual regulations, the conditions of participation. So this, I think, has probably thrown people on a wild goose chase, but I've met with CMS folks a number of times after this came out, and they readily acknowledged that this was an error, and in subsequent editions, including this year of the publication of these interpretive guidelines, fortunately this graphic is not there. But this December 11, 2009 publication is the thing everybody remembers and focuses on. So as I said, the Food and Drug Administration package insert, which has carried this text since the beginning, despite a multi-society attempt by the gastroenterologist to have it eliminated, is also the problem, because this is where the language about not involved in the conduct of the surgical or diagnostic procedure appears. That is not Medicare language, that is FDA language. So if you want to understand the essence of the problem, a picture's worth 1,000 words, and this is how I would sum up the problem with Propofol or Propofol deep sedation in gastroenterology. The gastroenterologist can't be giving it because they're engaged in the conduct of the procedure. The nurse is not a qualified anesthesia provider. Now, obviously, this means that if a second gastroenterologist came into the room, problem solved. But clearly, that is not their model. And the ISMP, ASA, AANA, and others echo this part, and I think all of us pretty clearly understand why that is cited as an issue in the administration of potent drugs, arguably Propofol or anything else used for procedural sedation. Now, I understand one of the concepts behind the use of Sedasis is the availability of a qualified anesthesia provider for rescue. And I think it's important to bear in mind that the last decade or so has seen a very significant shift of GI endoscopy procedures outside of facilities, particularly outside of hospitals, but to a large degree also outside of hospital outpatient departments. And if you look at these figures, you will find it relatively easy to understand why that might be happening. So this is an extract from the Medicare physician fee schedule, and this may be my time for revenge, because you can talk to to me about PKAs or something like that, and I won't know what the hell you're talking about. And I'm going to talk to you about RVUs, and I bet you won't know what the hell I'm talking about. So we'll call it even. But these are relative value units, and they come in three flavors: work, practice expense, and malpractice costs. So a couple of things about this. In the non-facility, that is the office or physician-owned ambulatory surgery center setting, it is the physician who bears the overhead costs. So the practice expense relative value units are very dramatically higher in this setting than they are in the facility setting. In the facility setting, the overhead costs are reflected in charges or facility fee to the institution, which doesn't exist in the non-facility settings. But as you can see, in both upper and lower GI endoscopy, the payment to the physician in the non-facility setting is roughly double what it is in the facility setting. The other thing to bear in mind about this is that about $40 or $50 or so of these fees is recognized by CMS and recognized by gastroenterology as dollars associated with the physician work associated with providing sedation. And so one of the considerations here in how people practice is that it these payments don't change when an anesthesiologist gets involved. So it costs nothing for a gastroenterologist to bring an anesthesiologist in. I kept on saying to these payers, well, why don't you just extract the $40 if there's an anesthesia charge? And that ought to generate some thinking on the gastroenterologist's part is when is it appropriate, when is it not? But you heard about the improvement in throughput, the reduction in liability and effort. Why wouldn't you, if you were a gastroenterologist, bring in an anesthesiologist? Now, on the Medicare side, the anesthesia fee is typically in this same ballpark. On the commercial side, the anesthesia fee for these things is in the neighborhood of $500. I mean, it varies obviously a lot around the country by the time of the procedure and by the contract, but as a rough rule of thumb, that's a big difference in the cost of this procedure. And I don't know, probably 12 or 13 years ago, I wrote a little essay in which I included back-of-the-envelope calculations that suggested that if all GI endoscopy procedures at then existing payment rates were associated with an anesthesia service, that it would be in the neighborhood of a $5 billion a year expense. And other people have published similar estimates, and actually as high as $8 billion with a B. I've seen. So you can understand why Medicare carriers and health plans have thought it worthwhile to address this. But so the point is that there are clearly understandable economic reasons, probably lifestyle reasons and convenience reasons for gastroenterologists to move the procedures out of facilities into offices. There is a phenomenon that Dr. Egan alluded to, in which the gastroenterologists actually hire on salary the anesthesia providers, be it a physician or a CRNA, pay them a salary, skim some of the anesthesia payments into their profits. This we've come to call, I don't know why we've called it this, but the company model. It raises all kinds of issues, because you then put the gastroenterologist who is making the medical decision about the necessity or need for the anesthesia services in a position to profit from it. Exactly the kind of things that Medicare anti-kickback and stark self-referral laws were meant to prohibit. And after many years, the Federal Trade Commission has issued a warning letter to say we are concerned about that practice and think that it is likely violating those those rules. But it is not, I guess my point is, it is not only relief from liability, increase in throughput, and enhanced fees that drive gastroenterologists into these arrangements, but you can pick up the GI or ambulatory surgery center throwaway magazines, and they have all kinds of articles in there about how you can improve the bottom line of the ASC and the GI practice by hiring your own anesthesia providers for this. So it is a seamy and kind of unappealing underbelly of medical practice there. But to the point where I started some time ago, to address this issue about anesthesiologist availability for rescue from unintended deep sedation or general anesthesia. This actually reminds me of another long and sordid bit of anesthesia payment history, which there are a few people in the room, by the looks of it, old enough to remember what we called local standby. And local standby was the concept that we might need anesthesia, and an anesthesiologist would make themselves variably available for a service and send a bill for standing by. And as it turned out, many anesthesiologists thought that standing by in their bed at home or in the golf course or wherever was a sufficient degree of standby and justified a bill. So obviously that got tightened down on, and the term local, this is probably the first time in about 20 years I've actually uttered the words local standby, because they've been expunged from our vocabulary. And what we call monitored anesthesia care was a term invented to replace local standby, which ceased to exist. But in the current procedural terminology guide published by the AMA, there is in fact this physician standby service listed there. But before you think you're going to be sending bills and get paid under this code for generally being available to rescue gastroenterologists, whether they're using Sedasis or not quite so fast, because most plans, as a matter of policy, do not recognize this code for payment. So we started by highlighting the term trained in the administration of general anesthesia, and this is kind of the line of argument that I've been trying to impress upon the gastroenterologists for a number of years. That somehow clearing the air on what that means would seem to be an essential part of being able to move forward on how we're going to care for these millions and millions of endoscopy patients. So clearly, holding a certificate from the American Board of Anesthesiology qualifies you as trained in the administration of general anesthesia. And I think that there are actually probably quite a few anesthesiologists who would say this is what's required, and probably quite a few anesthesiologists who have held ASA office would take that view. But I think we have plenty of examples out there of disciplines that have been successful in managing sedation without 4 years of training and certification in anesthesiology. And oral surgery comes to mind, and many of you in your own institutions probably train oral surgery residents who, according to their curriculum guidelines, must spend a minimum of 4 months rotating as essentially an anesthesia resident on a hospital service, and do a specified number of anesthetics and be certified in ACLS and PALS. And I think the use of anesthetic agents by oral surgeons as a consequence of this degree of rigor in addressing what needs to be known is not controversial, by and large. The other areas that probably may be a little bit more controversial than oral and maxillofacial surgery is emergency medicine, but I highlight this also because their curriculum requirements also very explicit about what they need to have done in order to complete their residency in addressing airway management and sedative administration. And while various independent organizations in gastroenterology have discussed this. They have not really laid down the law like oral surgery and emergency medicine have. And in fact, what they find is courses like NAPS, the nurse-administered propofol sedation, and this one, I'm not sure whether they're still doing it, but there are a whole lot of courses out there to allegedly train gastroenterologists and their nurses in the use of propofol sedation. And as you sit here through 5 or 6 days of 7 a.m. to 7 p.m. Continuing education, notice that this course in propofol sedation begins 7 a.m. Wednesday morning and Thursday afternoon, including a dinner, and there you are, you're ready to use propofol deep sedation. So my point is that somewhere between this and ABA certification is the place where gastroenterology needs to find itself in a non-optional kind of way to have some credibility, making the claim that that package insert, for example, should be removed from propofol. And so one of the things that I did at the beginning of my term was to say we cannot be mute as a specialty on this subject of what is the knowledge base and skill set, because we have that opportunity to lead, to assert our authority and expertise in this area. And so I appointed a group led by Beverly Phillip from the Brigham and Women's, and basically my charge to that group was, you need to answer this question, and I don't frankly care where you set the bar. You're gonna need to set the bar high enough that it's acceptable or palatable to your peers, but let's be on record about what we think is needed to be able to do this safely, and we just can't be the society of no anymore. And so this document, which is a fairly extensive one and goes into quite a bit of detail, the number of 35 cases or simulation experiences, pharmacology of this list of drugs, monitoring equipment. I recommend this statement to you. The following year, we took it up again with the idea of, okay, we've said what you need to know. Why shouldn't we be the group that is teaching this? And that proposition to invest in a curriculum failed in the House of Delegates by about five votes. One of the more controversial items in recent memory, and I was then very publicly a proponent of taking that on. I think it made sense for all the reasons you've heard, in addition to being a tremendous business opportunity. I mean, look at the Heart Association and ACLS. That kind of model would be available, but there was strong sentiment, I suspect, from the 48% territory to kill it. So feelings run hard. I can't do any better than quoting our vice president about why this is so important. And you already saw this RAND paper talking about, and I think their $1.1 billion of savings is a considerable underestimate. So the interesting thing that they did here, and it's probably going to be hard to see this, is that they looked so on the Medicare side, on the commercial side, they had actually ASA physical status data in the claim set. On the Medicare side, they looked at associated diagnoses and created an algorithm that assigned an ASA physical status, because those aren't typically reported for Medicare. But their point was, and their estimate in savings came from the fact that in the Medicare population, Between 65 and 80% of the anesthetics for GI endoscopy were given to patients with an imputed ASA score of 1 or 2, and they said that's where the savings is. And on the commercial population, it was about 85% of anesthetic services were given to patients with reported ASA scores of 1 and 2. The other thing here, and Dr. Egan already showed you the geographic variation, and in 2003, 13% of endoscopy services in Medicare patients had an associated anesthetic services. In 2009, it was 30%. 2003 commercial, 13%, 2009, 36%. So a pretty astonishing pace of growth, and you can see why the author of that other paper in the GI literature projecting 50-something% is probably not far off the mark. And in fact, if you look at the actual payments made under the Medicare program for these two anesthesia codes in 2012, $360 million, and that's the Medicare population. So not only is the commercial population more populous, the payment per case in that population is about double what the Medicare payment is. So you can kind of see why passions run high on this. This is a chart that I find deeply troubling not only in this context, but about what our specialty is or has become. You can't read it, but across the bottom line are 270 or so anesthesia codes, CPT codes, and this is the frequency with which they've reported, they are reported. That's what we do, and if you think about 12 years of training, that's not terribly satisfying. This is how the anesthesia payments break down. So somewhere in the neighborhood of 25 or more % of all Medicare dollars for anesthesia services are paid for anesthesia for cataracts and GI endoscopy. And the National Anesthesia Clinical Outcomes Registry, the registry run by the Anesthesia Quality Institute, shows that the top 3 most frequent procedures in the NACOR database are in fact exactly the same. So this appears to be verifiable from multiple sources. With that in mind, I mean, that definition of what modern anesthesia practice is kind of begs for some kind of solution if we are to remain viable. The other great event that occurred to me in my ASA president term was the publication of an editorial in the New York Times, which some of you may remember, saying that there was no longer any need for a medical specialty of anesthesiology. And I think the author of that editorial undoubtedly was familiar with this data. So I recognize that I've strayed a little bit from the assigned topic. I beg your indulgence and thank you for your attention.